Testosterone. It's a hormone we typically associate with men. But here's the kicker. Testosterone is one of our most abundant hormones. Yet, there are zero FDA approved testosterone therapies for women in the US. Meanwhile, there are over 30 approved for men. That's right, zero. So, why is no one talking about this? Why are so many women in midlife walking around with brain fog, tanked libido, depression, anxiety, insomnia, and muscle loss and being told it's just part of aging? Today, we're diving into the misunderstood, underprescribed, and absolutely essential hormone for women, testosterone. How testosterone may actually protect against breast cancer, boost cognitive function, improve heart health, and yes, wake up your libido and your brain. I'm joined by someone who's on the front lines of changing this narrative, Christine Farrell. Christine is a family nurse practitioner with a master's of science in nursing. She is a renowned specialist in the area of hormone imbalances in men and women and has been in practice in the area for over 20 years. She is an associate clinical professor at the University of California in Los Angeles. We're going to cover everything from why T levels often decline before estrogen and perimenopause, and to how testosterone might actually protect against the breast cancer, which is crazy. And you can find Christine at bioidenticalwellness.com. Christine, I am so happy to finally have you on the show.
Thank you. So nice. We've been communicating via Instagram for a long time, and I've been a big fan of yours. So thank you for having me.
And I've been a big fan of yours.
Thank
And
you.
and I've always really liked you, even though I didn't know you.
Thank you. Same, same.
Yeah, yeah. It's like I really like this woman.
I I feel like I've already known you until before today.
Right?
So, yeah, yeah.
Yeah, so I'm very happy that you're here. And I just want to start by saying thank you for all of the amazing education you do around hormones for women on social media, because you are a very strong voice and a very respected voice in this space. So thank you
Thank
for
you.
that.
Thank you.
Yeah.
Back at you. Back at
And
you.
you've been doing this a long time. Like you were just saying before when we were off air, when you started doing hormone therapy, it was kind of a like taboo almost. Like nobody's doing this. Everybody was listening to the WHI at that point,
Yep. Yeah.
because that would have
It
just been
was.
like just shortly after.
It was, you're correct on that. It was because I was practicing. I'm old enough that I was practicing prior to WHI. So I had come from a Premarin conference 2 months prior to the WHI publishing and
Oh,
being told hormones are the best thing since sliced bread, great for your heart, great for your bones, great for all these things. And then the WHI hit, and all of my patients get ripped off their hormones. And I'm watching the fallout. And that was horrific. Women who couldn't get out of bed. They had so much joint pain and brain fog, and they weren't sleeping, and on, all the symptoms we already know. And that is kind of what led me to the journey of looking for a new way to do this and to look at research on how important hormones actually are. But it's been a long journey. I was kind of the outcast in the area for a little bit, but I believed in it and I've been studying it, and I've seen it progress to this, which is amazing. So
and at that time, then did you stop prescribing for a while? HRT?
for a short while, because if you remember, I mean, we were getting black box warnings sent to our homes. It's the one time in history that I have ever had a drug manufacturer send me black box warnings about a drug that they were producing and saying, you need to stop it immediately. So, of course, it scared all of us. And I did stop. We had to tell all our patients, oh, you should probably go off of that. This is terrible. And then came the fallout. And I had a very close friend at the time, a nurse practitioner, who said, have you heard of bioidentical hormones? And she kind of put me on the path of studying, talking to one of the large compounding pharmacies in the United States, and just really starting my journey of education. So,
Wow. And so bioidentical hormones were just kind of coming onto the scene at that point and not obviously not being used very much or researched.
no, no, not at all. I mean, honestly, it was really, there was no such thing as a quote unquote bioidentical hormone at that time that was being mass produced. So you had compounding, you really had nothing else. We only had oral estrogen. We only had Prempro and Premarin.
Right,
So
right.
yeah.
And then, so when did you switch over and start actually prescribing again?
Probably within 6 months to a year after the
Good for
WHI hit.
you.
Yeah, it started slowly, but I had so many women. I was doing internal medicine at the time. I had a largely female practice, but I had so many patients coming to me saying, I can't live like this. I need something. And then working with compounding pharmacies and learning what little I could from the literature that was out there, which wasn't much. And honestly, Suzanne Summers, lover or hater, was
Love her.
was great about promoting all of this.
She really
And
was.
I am fortunate to be in an area where like Diana Schwartzbein was huge, which is who Suzanne worked with, originally. And got to work with some people who knew her and so on and so forth. So it was really kind of, you have to make your own way in this kind of field. It's
Yeah.
now there's actually education, there's FDA approved products and so on and so forth. But back then it was like the Wild West. But I saw a difference in my patients. And my own mother, who is in her 80s now, was one of those patients who got ripped off of hormones. And I put her on bioidenticals, and she has been on them since. And she does her little aerobics and her Pilates, and she feels great. So
Yeah. Yeah.
she's my living example of, how bad it was and how good it can be. So
Yeah, I did the same with my mom too, because she was in the WHI thing, which she was told to get off her estrogen immediately, and she had had a hysterectomy in her early 40s and had been on just progesterone. And
wow.
only no one would give her anything else. And so when she was in her 60s, she started getting cognitive issues. She was still having hot flashes, which
Wow.
is crazy.
Right.
And she's finally was gaining the weight, the menopausal weight in her 60s. And so I said to her, I said, you got to start estrogen. And her dad died of Alzheimer's. So she's always been petrified of it. And I said, look, here's the research on this. Here's how important estrogen is for the brain. And she's like, give it to me now. And she's like, I
Yes.
will never go off of this. Like she immediately lost the weight. She said her cognition came back. Like she's just like, yep, I'll never go off of this.
Yep. And I love that because that's a great example of the whole, do you have to start it at a certain time?
Yes.
Should you ever go off? No. Is it too late to start? No. I've
Yeah.
seen the same. I've seen patients one of my patients brought me her mother, who is in her late 70s having significant cognitive decline, and said, let's try it. Anything. The woman went from having hallucinations and calling, crying every night to still having cognitive issues. She's already got some damage, but significantly improved. So
Wow. That's a
just,
good story.
and that late in life. So it goes to show you
Yeah.
how important it is, and that it never really is too late.
Yep. Yeah, I agree. I agree. So you won't turn anyone away.
No, no,
Good for you.
no,
I love
no. I
that.
think there's a way to treat every single patient.
Yeah.
It really is.
Yeah. So something that you and I talked about before we aired that I want to bring up to my audience because I am never afraid to say I was wrong. I'm always super open to learning and to figuring things out as I go along. And I have always been told, as have you,
Yes.
that testosterone is a woman's most abundant hormone. And I have touted that on so many podcasts where I've been like, testosterone, it's the most abundant hormone. We have some of the top hormone experts in the world saying this, which is why I believed that was the case, why you believe that was the case, why,
Yeah.
and you can even find it in some paper, like here and there. But when I was doing the research for this podcast, I wanted to say, like, oh, we have X amount more testosterone than we do estrogen
Right.
to shock everybody with that stat
Yeah.
because that's what I had heard. And
Right.
I couldn't find any research to back it up. And so when I asked you, you said the same thing. You were like, yeah, I can't find any.
I can't either. Because just like you, I keep hearing it, and then I've been touting it as well, and then started looking into it and going, well, that's not really making sense. And as I said to you, in clinical practice, if we see a woman who has a higher amount of testosterone than quote unquote normal, we start being concerned about other issues like PCOS, et cetera.
Yeah.
And then there's also, which is interesting, this whole backlash right now with testosterone of using, abnormally high dosages and how wrong that is. So that isn't making sense. It's like we're talking out of both sides of our mouths in this menopause world right now. It's the most abundant hormone, and yet don't use too much of it and masculinize women. And so, right, it doesn't make sense. So,
Yeah, right?
yeah,
And everything I just read was no, estradiol is a woman's most abundant hormone.
yeah, it's what makes
And
us
it's
girls.
not by much, it
Right.
looks like, but
True.
it was there.
Yeah.
So everybody, this is, I mean, Christine and I are gonna have to look into this a little bit more and maybe talk to some of these other practitioners that are saying this, that seem to
Yeah.
be quite the experts, and ask them if they have proof of this,
Yeah.
because as of right now, we can't find it.
I'd love to get, if somebody's got information,
Yes.
please send it because I do want to
Yeah.
understand where you're finding this information because I don't see it out there. So is
Yeah.
testosterone important? Yeah, absolutely. But is it the most abundant hormone in men? Yes, but in women,
Yes.
not typically in my research. So
Mm.
yeah,
At what point in your practice then did you start to say, I think I need to also be giving women testosterone? Because I would guess that that wasn't something you were doing 20 years ago.
correct. When it first started out, I mean, nobody was doing testosterone in women pretty much at all. I would say about 4 or 5 years into the journey of treating with bioidentical hormones, it even became an option, where I was hearing from some of my teachers and some of my research that testosterone, great for bones, obviously for libido, cognition, skin, all of these different things. And I would say about 4 or 5 years in, um, started using it very, very low dose. I've always, was always super cautious about it because, again, so little discussion or research about it at that time. But then I
Mhm.
did see huge improvements in my patients with their energy and their muscle and just their general joie de vivre. It's like everybody felt better. And I was thinking, oh, okay, well, I'm onto something here.
When do you see that it's starting to go down in women? At
I
what
would
age?
say that's a good question. It depends on the woman.
Hmm.
Typically somewhere the usual, though I've got younger women who do have these issues, 35 to 45 is kind of where I see it. That perimenopausal drop off is when I tend to see it the most.
Yeah, yeah. Do you think that there's a lot of the stress factor that's coming into the loss of our testosterone because we make so much of it in the adrenal system?
Correct. 100%. And I
Okay.
will very much see that if somebody says, look, I've had a horrible year, they're a new patient, name, 5 different major stressors, and I'll see this testosterone level that's completely abnormally low. And sometimes I'll see that in a woman who's still making normal amounts of estradiol and progesterone. So then that shows you how adrenal it really is and how
Yeah.
stress really, really impacts it.
Hmm. And then you went on to train with a physician that was using testosterone pellets and using testosterone pellets in breast cancer. So
Yes.
talk to me about this woman.
Okay, so I had pellets weren't even on my radar. And new patients would call me and say, hey, do you do pellets? And I'm like, what are pellets? So that set me on a study of looking. There was a guy, I won't go into it too much. There was a guy who was doing it really more like a, treat 'em and street 'em kind of a thing, all about high libido. And then I found this Dr. Rebecca Glazer, and she has been around for a very long time doing pellets. She's a breast cancer surgeon in Ohio, has an ongoing study looking at treating breast cancer survivors with high dose testosterone pellets, where she won't give them estradiol, but she would give them the testosterone. And her ongoing research has shown about a 40% reduction in breast cancer recurrence in these women. So, and alleviation of many of their menopause symptoms by using the testosterone. So, I opted to go and do a training with her, and you go and spend about a week and, do didactic, and then get into the clinic with her patients and learn how to do pellets and speak to the patients. It was fascinating because I had women who told me they've never felt this good in their entire lives. And they, the side effect profile was not bad on, some of these women were getting very high dose, mind you. But doing great, no recurrences of breast cancer, and her studies are pretty remarkable. So she's kind of like I was back in the day, where people still look at a lot of her research and think, she's the outlier and so forth. But her research is ongoing and been pretty solid
And replicated at this
and
point.
replicated now. Correct. You're correct. Yeah.
Yeah, yeah. I want to talk about some of these studies because when I saw these, I was blown away, and I can't believe that more people aren't talking about this because breast cancer is such a hot topic, especially in the HRT space, and
Yes.
everybody's worried about it. And then you start reading how many of these studies showed that same, like a 40% reduction even in tumor size
Correct.
after
Yes.
a period of like months.
Yes. Yeah.
It's like, why is this not being used?
I know. And that's something I still don't understand. I truly don't. There's still this huge fear. You and I were talking about this before we started, that testosterone will aromatize to estrogen.
Mhm,
And
mhm,
so
mhm.
therefore we don't want to give any breast cancer patients testosterone. In my own studies, because I've had patients say, please God, give me something. So we'll talk about the risk benefit alternatives. And we've done testosterone. And I see little or no aromatization. And if there is any, then we put them on a blocker. But for the most part, I've done high dose testosterone in some women, alleviates their symptoms. Side effects are minimal, and I see no aromatization, zero. So zero change in their actual serum estradiol levels. So there
Do
you
you have
go.
a theory behind why? Because I mean, when we look at the hormone chart,
Right.
it's supposed to be that, testosterone, DHEA can convert down and make estrogen.
Yes.
But like you, I just don't ever see this happening. Like when women are on testosterone therapy, I don't see this massive rise in their estradiol or their estrone.
What's also fascinating is that I do see that in men. I really try to
Yes,
watch my male patients on now, granted,
absolutely.
they're on typically much higher dosages than women, right? So you could imagine if you take this large amount and then aromatize it, you're going to get more. But even the patients who have come to me, I was mentioning to you that I've taken over a practice for somebody who's not practicing any longer, and she was using very, very, very high dose testosterone in a lot of women, some that weren't even breast cancer survivors, and their estradiol was still exceedingly low. So we've actually been trying to switch that a bit, but um, it's fascinating. I don't know. I really don't
Okay.
understand why you see it in men and you don't see it in women. And because women, we have more body fat, so typically you see more estrogenic effects in somebody who has a higher level of body fat than somebody who doesn't, which is typically a guy. So I don't know.
Yes. Yeah, I
Very
don't know
interesting.
either, but
Yeah.
clinical experience,
Correct.
definitely. Even when I spoke with, pretty sure it was him, Dr. Kyle Gillette.
Yes.
Yeah, very smart hormone guy.
Yeah.
And he said the same thing. He's like,
Yeah.
you just don't see it very much.
Yeah.
You don't, very little converts, he said.
Yes, very, very little converts.
Yeah.
And I know, you and I talked about some of the studies with pellets and implanting them directly into
Yes.
the tumors. They were using, an aromatase inhibitor at that time. And I think it was an anastrozole combined with the testosterone in these estrogen receptor positive tumors and seeing a massive amount of shrinkage of the tumor, which is crazy. So that kind of confuses the picture a little bit for me as far as, was it the testosterone, was it the anastrozole? Hard to say in those particular studies, but there's a lot of research just on testosterone alone with no aromatase inhibitor and still getting, like we talked about, that that huge reduction in breast cancer.
Maybe
So,
just quickly explain what an aromatase inhibitor is for those that don't know what that is.
okay, so testosterone, like you were saying, the chart of how hormones break down from one to the next is testosterone typically it can go certain different pathways, but one of those pathways is to estradiol. And that's called aromatization. So we sometimes will give, particularly like in men or in women with breast cancer, something to stop the body from converting other hormones to from aromatizing to estradiol. It's like an estrogen blocker, essentially.
Mm-hmm, mm-hmm. There was a 10-year cohort study where they had 1,200 women on testosterone pellets. They
Yes.
had a lower breast cancer incidence than
Yes.
age-matched national data. And then the group that had testosterone plus an aromatase inhibitor had an even lower risk.
Yes. I saw that. Pretty
Yeah.
amazing. I mean, they are looking at androgen receptors seem to down regulate tumors, breast cancer tumors. That's what I've been reading. And so that's the thing that I still don't fully understand the mechanism behind that. But the research does seem to bear that. And of course, we haven't had huge studies yet, which is why you're probably not hearing about it as much. But it's out there. I mean, you and I both can find the data. So,
Mm-hmm, mm-hmm. Here's another one.
yeah.
Implant in the breast tumor 60 milligrams of testosterone. This is via pellet with 4 milligrams of the aromatase inhibitor and anastrozole. There was a seven-fold tumor reduction in just 46 days and 12-fold by week 3.
Amazing.
I'm like, if I get breast cancer,
Right?
I'm flying to California and you are going to implant a testosterone pellet in my breast, just so you
Right in
know.
your tumor. Yes, I will. I will take,
Thank
I'll
you.
come see you. I'll fly to you.
I'm like,
No,
who would do this? I mean,
yes,
right?
it's amazing. No, I mean, it really, and you and I were talking about why are pellets getting such a bad rap?
Yeah, let's talk about this.
And you brought up that you had in another podcast exactly what I would say, which is people didn't know enough about pellets. And then all of a sudden, you have a particular company, I won't badmouth anybody, who's decided that if you come in as a provider for a weekend, we'll train you how to do pellets, send you on your way, and you are part of our quote unquote group. They train you with an algorithm. Everybody pretty much gets the same high level dosing, and women are having, some women feel great, not going to lie,
Hmm.
there are some
Yep.
who've said even with that protocol they feel good, but you're
Yep.
taking providers who have zero hormone training. Just because you went to medical school does not mean you know how to treat hormones, and giving them license to prescribe hormones at very high dosages and without really a knowledge as to why or the side effects, et cetera. So we're seeing a lot of backlash from that, and I personally believe it's really given pellets and hormone therapy, particularly testosterone pellets, a bad name.
It really has.
Yeah.
And people ask me constantly, what's your opinion of pellets? What's your opinion of pellets? And I always say the same thing, which is I know so many women that have done amazing on them, but I know so many women that have done absolutely horrible on them.
It's
And it's always the same story. It's like they got the insertion and they suddenly break out in cystic acne, they're losing their hair, they're getting fat, they're water retentive, and they've got to wait it out for 3 months before that
it's
goes anywhere. One woman, it was like 20 pounds of weight of just water and just horrible. And I've seen women's labs where their testosterone is, 1,000,
my
or
gosh.
higher because
Yeah.
they just had these pellets put in. And it's like, oh my gosh, this is a disaster. And so I definitely for a while was very like anti, like, no, don't do this. But then I was like, you know what though? There's so many women that feel good on them and that are doing them.
Yes.
And so then it comes down to who's doing them, I think is
Right.
really what it comes down to. And then what I always say is, great, if you think that pellets is something that you'd be interested in doing because of the ease. I mean, come on, you put them in, you don't have to do anything for 3 months. That
Right.
is nice.
Yeah.
Maybe don't let that be your first
Correct.
way of trying testosterone therapy. Like I would never have thought that I was a high converter to dihydrotestosterone because I'm so estrogenic. I'm not androgenic person. And when I first started on testosterone injections, I was put on 20 milligrams a week injection. And within 2 weeks, I looked like I was 16. I was total pizza face, acne
Yep.
all over I was getting chin hairs. I was like super
Wow.
greasy skin. It was horrible. And I was like, oh my God, I do not process this well. And it wasn't until I did genetic testing
Oh,
as well, combined that with my Dutch testing, that I saw, oh my goodness, I would be the worst candidate for pellet therapy. And
exactly.
most women don't know this. They haven't done genetic testing. And if they have, they probably haven't had it really explained to them properly. And a lot of women haven't done a Dutch test either to see if they highly convert into dihydrotestosterone.
Correct. And I think that is a very, very good point. I do not start patients on pellets, period. I always tell because they'll come to me and say, oh, my friend so and so is on pellets. I want to be on pellets. And I'll say, you're not your friend. We don't know how you're going to react to hormones. And if I put this in, you're stuck with it for 3 months. So, that being said, let's start you on something, see how you feel, see how you tolerate it, find your sweet spot. If you still want to do pellets, great. But it is important to mention too that pellets come in all kinds of dosages, very low, very high, and lots in between. So I always start somebody on the very low end and then work them up to where they feel good. Again, because I can always add hormones, right? But I can't take away what's in your pellet. And I don't want anybody to be feeling miserable for 3 months. I mentioned to you, I have literally tried every hormone. I do this for a living. I've been doing this for 20 something years. I've tried everything. Pellets are the only thing that I feel good on. The only thing. And it has to do with, I think, the slow release, that you have the slow, continuous amount. I get migraines really badly, and I
Same.
don't get them with the pellets. I get them at the end of my pellets, how I can always tell my pellets wearing out. Um, I love the convenience. Yes. Do I love having a tiny little incision in my glute every 3 months? No, I don't. If I could find another way, I might go with it because I don't want to do this for the rest of my life, but I feel fantastic. So, trade off. Again, you have to find the right thing for the right patient. I think that's the biggest key.
And do you tend to lean more on the side of the lower dosed ones? Like, do you see that working better as far as the side effects go?
I do.
Yeah.
Absolutely. I definitely do. I know I have a handful of women who they're like, give me more, give me more, give me more. And they feel great. And I will give them, say 100 milligram testosterone pellet, where I personally cannot tolerate more than like 37.5 with my estrogen, but I'm on estrogen as well. So it's very, very, and I've got women who are on 12.5, like the very lowest dose pellet. So of testosterone with some estrogen, et cetera. Everybody's different. It's really, I think that's the key. I always say our pregnancies are different, our periods are different. Why would our menopause not be different? And like you said, our absorption, the way we break down and excrete our hormones in our body, everybody's different. So you can't just say, oh, everybody gets this high dose pellet or nobody gets pellets. There's a lot of, nuancing to this.
Do you use estrogen pellets as well?
I do. I
Yeah.
do. In women who have a uterus, it's tricky. You do see more bleeding. And Dr. Glazer, who I trained with, was not a big fan of using estradiol in women with uterus because she said they feel good, but the incidence of bleeding goes up, and that's difficult to deal with because the FSH will drop. So the person's brain is going, hey, look at me. I have this tiny ovary again making estrogen 24/7. I think I'll start having periods. If I keep it on the low end, I typically, with the right amount of progesterone, I typically don't have that. In a woman who doesn't have a uterus, I can dose her to a more young physiologic level, and they feel pretty darn good.
I
So,
bet.
yeah,
The testosterone I find like it's just across the board. Happens in our clinic where women are on it and they feel so good. And they're
Yes.
like, oh my God, I feel so amazing. My energy's up, my libido's back, I can put muscle on, all these great things. And that tends to be over time, it starts to build up and they feel amazing.
Yep.
But then it almost with all of them, there's this like turning point where that dose becomes too much and their body starts to have all of these androgenic symptoms. And the number one thing is they start to lose head hair and they start to grow facial hair.
Yeah. Yeah. I tend to see that it's interesting. I have some patients that never happens to. I have other patients. I am one that I will lose if I went too high on my testosterone. First of all, I get very cranky. And number two, I will lose hair. My hair will start to fall out. So
Yeah.
I have to keep it very moderate. And again, it's when we talked about testosterone being the dominant hormone, if my testosterone becomes dominant, I will lose hair. If my estrogen, testosterone are balanced and more normal physiologically, I don't lose hair. So, you know, it's
Yeah.
there's that.
I just think that in those cases, it's not natural.
Correct.
They feel really good. It's a steroid hormone. They feel amazing. It's like, yeah, I bet you do. This is what guys feel like. This is why we
Right?
have the short end of the stick here, ladies.
Exactly. So true.
Women will say that they'll be like, oh, I get it now. I
Yeah.
get why my husband wants sex all the time.
Exactly.
If I felt
Exactly.
like this, yeah.
All right. Exactly. That's
And
I
then I
have
always
heard
say
the
it's
same
too
thing.
bad because now you're
Yes.
losing your hair and you're growing a clitoris. So we got to
Right?
stop, right?
Exactly. It's so true. And it's so true. But there's a happy medium, right? I mean, we can
Yeah.
definitely, and that's a whole other conversation, sex driven women and how our brains work versus how their brains work and all that kind of stuff. But it definitely can kind of wake up that brain piece. I can tell you personally, cognitive wise, when my testosterone is low, I'm a completely different person. I feel like, and my migraines get worse. So the testosterone has really, and that's something, again, I can't find good research on why um,
Mhm.
testosterone and migraines, but it really does make a difference for me, big time.
It does. And I've talked on my podcast about this before, and I've had some people come on to talk about it as well. But the use of androgens,
Yes.
not just testosterone, but the use of things like anabolic steroids, oxandrolone, nandrolone. For those that don't know what those are, these are anabolic steroids that are typically abused in the bodybuilding world to put a lot of muscle on very quickly. But we do have some receptors for these, which a lot of people don't realize. They have been utilized for my chronic migraines and other female gynecological issues like endometriosis. And I read about this from a doctor, Dr. Lichten, his name was, and I had heard him on this really old podcast talking about using androgens for migraines. And I'm a chronic migrainer. So I'm like, at that point, I'm like, I will try anything.
Right?
And it's
Absolutely.
not legal here in Canada. So I actually had our doctors prescribe me oxandrolone and
Oh,
I get it
interesting.
shipped up. So
Yeah.
don't tell anybody, please.
I didn't
Um,
hear it.
and it really helped. It
Really
did. It did.
interesting.
It substantially brought them down. I was on 6 milligrams a day.
Okay.
And I actually went to 3 months and then my blood work started to go down. Like it starts to negatively affect you. It's hard on your liver, things like
Liver,
that. So,
lipids. Yeah.
yeah. And my HDL actually went below range.
Oh,
And I was
interesting.
like, ah. I would say probably reduced the migraines by about 50%.
Wow.
Yeah.
That's fascinating to me because you
Yeah.
got to wonder then what is the mechanism. That's something I need to do more research on because that is fascinating.
I think I kind of came onto this theory around it because there's not enough research on it.
Right.
But my theory is a lot of these migraines that are tied into our hormones
Yeah.
are actually not so much triggered by the actual hormones themselves, like estrogen, progesterone, or lack thereof, or sometimes it is, but a lot of the
Fluctuation.
time it isn't the fluctuations.
Yeah.
What I realized was if you took it a step farther, it was the fluctuations of gonadotropin releasing hormone.
Okay. Interesting.
Oxandrolone blocks that.
Oh, that would make sense.
Yeah. Yeah.
That's very interesting.
Isn't it?
Huh. Yeah, there's got to be, because, I mean, we've got all the CGRP inhibitors now, which I take those too.
Same.
Um, and it's beneficial, but migraine is so understudied and it's so prevalent in women and it's so prevalent in women with hormonal fluctuations. So they say it gets better in menopause. I have not experienced that yet, but
Nor have I.
yeah,
And I'm on daily medication now too. Do you
yep,
find that you see that in some of your patients too with migraines, that the testosterone pellets help?
I do. I really do. And I have found that testosterone helps pain in general. That's an interesting fact, too. There was a study in the journal Pain quite some time ago that showed a significant reduction in generalized pain syndromes in women who were on testosterone. So, again, is that dopamine related? Because it does upregulate dopamine receptors. Hard to say. But they did find it to be beneficial. And I have really found that it helps joint pain in like my perimenopausal women, some of my chronic fatigue patients. I have an older lady who I've been treating for years. I think she's in her early 80s now. And her fibromyalgia has been hugely improved by testosterone.
I
So
didn't know that it upregulated dopamine receptors.
does to a degree. Yeah.
Yeah,
Yeah.
great.
So whether you just feel happier and you feel less pain, I don't know. But yeah.
Right? Yeah. Either
Yeah.
way. And it showed too that one surgical study found low testosterone predicted worse recovery after major surgery. And
Interesting.
so it's should we, was saying like, should we maybe be screening women pre-surgery for their
Yes.
testosterone levels, which will probably never ever happen. But
Well, and then that leads to the question of what's quote unquote normal testosterone, right? Because
yes,
right, the ranges that we see as normal are 2 to 45, like on a general lab test. But
two
if
to
somebody,
45.
right, and if
If
somebody's
you're
at
two, you're
2,
fine.
yeah, right, you're good. Oh, look, you're normal. You don't need anything. But when I see somebody at like 3 or 4, I'm like, how are you functioning? How are you getting out of bed? They feel horrible. So how is that normal? How do we call that normal for a woman?
No. Where do you like to see well, first, a woman not on any HRT?
Yes.
Where do you go, okay, you need testosterone with her total testosterone as well as her free testosterone levels? People always want to hear the numbers.
Right, right, right. You know, with total, if somebody is below 20, I'm usually apt to treat because I am a big believer. I have watched osteoporosis start to reverse in women who have testosterone. And we talk about, the musculoskeletal issues that occur in perimenopause and menopause, massive improvement in that. How many women come to me and say, "Oh, I'm super happy with my body"? Zero. Right. So if I can help
Said
them,
zero menopausal woman ever.
yeah, right, exactly.
Right.
So if I
Yeah.
can help them with lean muscle mass, with cognition, this and that, I really am a believer that it has huge health benefits. So I would say if you say 20, if you're below 20, I'm more apt to treat.
Yeah.
Um, that doesn't mean that somebody has to go on it at all, but that's typically kind of my cutoff point. That's on a total. On a free, anything that really I like them to be at a one or above when it comes to free. I want to see the highest amount of free possible for my patients. So,
Yeah. And
and
then
usually I
once
run them
they're
above the normal too. So
okay. And then
I'm
so
free.
on HRT,
Yes.
are you still looking at total or are you mostly focusing on the free or do you like to see both?
I like to see both. I usually
Hmm.
do like to see both because I would say free is a percentage of a total, right? So I want to kind of know what is my total amount. And on top of that, what is the non-bound free that we're actually getting any use out of? Because again, I can have a total of 50 and have a free that's very low, or I can have a free that's high. But again, it's a percentage of a small amount of testosterone. So I like to see my testosterone ideally, again, depends on the person, but somewhere between 40 to 60. I tend to run my patients above normal. And then
Hmm.
I want their free to be somewhere like 3, 4 usually or above.
Same.
So, yeah.
Yeah. Yeah. I find that pellets, injectables really overshow in total.
They do.
Yeah.
They do. They do. And then, that leads to the question of, since, for example, estradiol, the ultra sensitive testing now is so much different than it was when I first started in this. So I have patients who, for example, if they put any topical testosterone on that morning, I will see these abnormally crazy high levels, right? Because again, even the tiniest little bit of contamination can skew your test, so that it makes you think,
Hmm.
and this is just my brain, if I'm putting a pellet in the subdermal tissue and you're getting a continuous amount of testosterone in the bloodstream, how accurate then is my blood level? You know what I'm saying? When it looks like it's
Hmm.
150, is that a
Hmm.
true number, or is it because of the fact that there's testosterone being put into the bloodstream 24/7? So
Yeah.
that's the tricky thing. Is that my actual serum number? I don't know.
Yeah. Yeah. I wonder that too. I don't know what the answer is. It's like every hormone has a different, like progesterone, topical progesterone doesn't show in blood work, and then it way overshows in saliva. Estrogen seems to be okay in both urine and blood. Like it seems to be a pretty great way to test our estrogen levels,
Yeah,
except for estriol.
right.
Estriol doesn't show up in blood work.
No, not at all.
It's always 0.1.
Yeah, exactly. I was just going to say point one. Every single
That's
person.
it.
Yeah, exactly.
The doctors we work with, they were always like insistent on getting estriol tested. And I'm like, why?
It's not going to show anything, but okay. Yeah, I know.
Right?
Same. Every time. I don't even test it any longer for that reason. So,
No, there's no point. Yeah, it's so weird. And then the testosterone, it's like it overshows in blood, but then you look at the free and that seems to be pretty
yes,
accurate.
that's what I was going to say. When I've got somebody on pellets, the free tends to look normal. So that is actually a very, very good point. So it goes to show you that, yeah, that you may be seeing this skewed number on the total, which of course freaks other providers out.
I
What is
was
she
going to
trying to
say
turn
that.
you into a man?
It
And
freaks the patient out, it freaks the
yes,
provider out. They're like, oh my God, you're at
yes,
100 or whatever it
right.
is. But then you
I'm
look
a
at the
guy. No,
free.
you're not. Yeah.
No.
Yeah. But then you're right. Then you look at the free, and the free is 3. And you're like, oh, you're fine. So,
Yeah, yeah.
yeah.
How do you see testosterone cream working? I don't personally see it working very well.
It depends on the patient. I find that transdermal really varies. I've got some patients who
Yes.
hyperabsorb, and I've got some who, I am one who does not absorb. And I have a good number of patients who, doesn't matter what dose I give them, whether it's estradiol or testosterone, I can't get their levels up.
Yeah.
And, those are people who pellets are typically a better solution for. But yeah, it's testosterone topical. The thing that I struggle with is that you're getting such a bell curve, right? So you're getting like a high dose in the morning and then nothing for the rest of the day. So if you dose it small amounts twice a day, a little bit
A little bit
better.
better.
Some of my patients, give them a click or two of, a topic click in the morning. They feel great and they're fine. So yeah,
Yeah.
everybody's different, you know?
I had a few people that where they were rubbing their cream, they grew hair.
Yes. Yes. Well, I always tell them, do not. So my trick is rib cage over here, shoulder. That's about it. Because any other place, don't do thighs, don't do forearms, because you will grow hair. Biceps, shoulders, and rib cage. I've yet to have somebody get hairy in those areas. So
I always
that's
say
it.
labia because there's
Oh,
hair
that's a
out there.
good one
But
too.
but nowadays women get buck everything off down there and they
That's
don't want
true.
hair down there.
That's
But I'm
true.
like,
Yes. Yes.
if you're
Intravaginal,
rolling with the 70s look,
right?
then this could
You're
be
good.
totally fine.
Yeah. Yeah, but if you're trying to do laser hair removal, you just don't waste your money. It's not going to work. Yeah. Yeah. But it does
No.
it does intravaginally, it works really well too. I get great
Hmm.
numbers. But again, then, not everybody wants to deal with the mess and the fuss. So
No, that's how I used it first was cream in the vagina. I didn't like how messy it was, and I also worried about what was in the cream. It was a
right,
compounded cream, and I'm like, as if this was made for vaginal microbiome. I
right,
don't think
right.
so,
Good point.
right? But it did absorb well, and it was great for the vaginal tissue, but
Yes.
I wouldn't go back to that.
Yeah. No, and it's, I use it sometimes like with pelvic floor physical therapist. I will make a compounded vaginal specifically for the vagina cream. that's a little estradiol, a little DHA, a little testosterone, because it is really good for, some of the musculature as well as obviously just the tissue in general. And
Hmm.
it can help with some of the spasm of the urethra and some of the helping with the levator ani muscle and all that sort of stuff. So you do see some benefits in vaginal testosterone, but again, it's messy and
Hmm.
it's nobody's favorite way to do it. So
Yeah, because it's really good, isn't it, for urinary incontinence?
yeah, works great.
Yeah,
Really
I've
does.
heard that. I've heard
Yeah.
that
Yeah,
before.
I've had
Yeah.
great success with that. Just a little dab right underneath the urethra
Okay.
intravaginally, and it seems to really strengthen. There's a muscle, the levator ani, which gives men their erections, but we have the same little weak muscle in there, and that tends to help lift the urethra up. So it's beneficial.
Yeah. And what about trying to avoid receptor fatigue, receptor saturation? Because testosterone, I find, definitely has that effect. Once again, I find all hormones kind of act differently like that. Like I don't see it with estrogen, where estrogen
True.
can be given all day long, every day, and women don't seem
Yes.
to adjust or get a decrease in symptom relief or anything like that. With testosterone in men and women, I find like across the board where they'll say, when I first started testosterone therapy, I felt so good. And then, 3 months, 6 months in, I don't get those effects anymore. But if I go higher, I do.
Right. And that's interesting because sometimes the blood levels will still look good, and
Hmm.
yet they don't. I always call it like the virgin pellet experience. You get your first pellet, you're like, oh my God, I've never felt this good in my life. My libido is amazing. And then 3 pellets down the road, I'm getting the same comments like, where's that high? That is a
Hmm.
good question. Is it, receptor fatigue? Is it that you're just not getting that initial exciting, rush? That's a good question. I don't know. I do find with testosterone, if I like to rotate sites, and surface area is huge. So I tell women, what we're told, like, oh, put things on your forearm. So they're kind of just rubbing this little tiny area. I'm like, no, no, no. You need to really use some surface area. You need to, do your rib cage, move it around, that sort of a thing. It
Hmm.
tends to, again, it depends on the patient. It really does.
Hmm.
Some
There's
women
been,
have done great on it for years. So
and I've seen it talked about in the male world of
yeah,
testosterone therapy.
yeah,
And there's a lot of HRT clinics that deal with men solely that are now doing a cycling of testosterone as well as doing 2 injections a week. So
yes,
I've seen 2 injections a week rather than one.
correct.
And and then also cycling the amount so that there's some weeks where it's dropped in half. I tell my husband, I'm like, just, once a week or a week out of the month, drop it in half. And then sometimes on occasion, completely miss your dose. Like just go two
Yes.
weeks without anything.
And then you'll feel, and they actually do get that rush again. That's true. I tend to prefer twice weekly subcutaneous testosterone injections for men because it kind of mimics almost a pellet for them. I see less issues with elevation in hemoglobin and hematocrit. I see less issue with aromatization, and they tend to feel a lot more stable that way. Now, not every guy wants to do twice a week shots because they don't love shots, but it does tend to work. I've actually seen, there was a study I saw using daily sub Q low dose testosterone. I have a couple guys who do that. I do not see elevations in their hemoglobin and hematocrit. I mean, they're very stable. They
Oh.
do beautifully, but again, it's daily.
Can you
So
explain that, the hematocrit and hemoglobin? Because that can happen to women too. It's definitely
true.
more to men because they use higher amounts, but can you explain what's happening there?
We do see with the testosterone that it can make the bone marrow produce more red blood cells and more hemoglobin and hematocrit, which then makes your blood thicker. And for a woman or a man, it's not ideal. There is a urologist that I know locally who's a very smart guy, and he has said that we over panic about. He's a big testosterone pusher. We over panic on H and H being elevated. I'll allow it to be maybe a point or two up and I'll watch it. But when it starts to creep up to 3 or 4 points above normal, I get concerned because nobody needs sludgy blood, especially when you're looking at somebody over 50. We've all got a little bit of plaque, not all, but most of us have a little plaque. And plaque and sludgy blood are not a good combination. So
Yeah, because what can that lead to?
strokes and heart attacks.
Yeah, thank
Yeah,
you. Okay.
that things we don't like. Yeah, yeah, yeah. So that's kind of my thing. So yeah.
If somebody's is going up as a woman, let's say we're just talking about women here, is there something she should be doing then that could help that, or should she just be lowering her dose?
I usually say we should lower the dose. That is
Okay.
something. I do have two gals in my practice who have chronic elevation in their hemoglobin levels, and they have since they were very, very young. So it's interesting because they're on testosterone, not high dose, but every time they go to a primary, the primary goes, "Oh my God, it's because you're on testosterone." It's like, no, I had this when I was 17. This is a genetic issue. So in those cases, they actually have therapeutic phlebotomy done periodically. And I do recommend if somebody is running high and they like their high dose, I have them go donate blood.
Okay.
The world needs more blood anyway. And, it is very, very helpful. You take a pint off and usually the hemoglobin hematocrit come back down to normal. But yes, I typically try to lower the dose then in those patients as well.
Hmm. How does testosterone help cardiovascular function in women?
That's a good point. It improves arterial elasticity, which is huge. So you think of the arteries as being more elastic. That means you're going to have typically better blood pressure control. It does tend to vasodilate. So it's, again, opening up blood vessels, getting better blood flow everywhere, including to the genitals. But when you dilate blood vessels, you tend to lower blood pressure. And you're getting more blood flow to your heart, to your brain, to everywhere. People think of testosterone as raising your blood pressure because they think of the angry man, but it actually has some really great cardiovascular benefits, as well as, it got a bad rap for lipids. I know you know this. Um, and now we're finding that that may not be the case at all. So,
Yeah.
which is great.
Yes. And then for bone health, like this
Yes.
is the thing is testosterone, it's not just about libido. Everybody thinks libido and muscle, and
Yeah,
then they don't take it any farther.
correct.
So I want to go through some of these other amazing things that it does for women.
Yeah, testosterone, all the drugs that are on the market, like Fosamax, et cetera, they are osteoclast inhibitors. So there's two little cells that help with your bone development: osteoblasts, which make new bone cells, and osteoclasts, which clean up all the old crappy bone. Well, if you're taking a drug like Fosamax that stops your body from these osteoclasts from cleaning up old bone, your bone density will look better on a picture, but you've actually got crappy old bone in there. And that's why oral surgeons hate it, because you end up with necrosis of the jaw, et cetera. Testosterone is actually stimulating osteoblastic activity. So it's making your body make new healthy bone. So I've yet to find anything ever that works on osteoporosis and osteopenia like testosterone. I will take little old ladies that are fragile and I will put them on it and their bone density gets better. My 80-something-year-old mother has great bone density. So, and I've had her on testosterone for a very long time. So,
How does that differ from what estrogen does for the bones?
estrogen works more like osteoclastic. I can't say the word osteoclast inhibition. I can't say it. So one
Okay.
is keeping your bones from breaking down, and one is building back up. So
Building.
those two in combination are beautiful,
Ooh, I love
right?
it.
Yeah. So
Yeah.
that it's the best, the most natural. Exercise, hormone therapy, and good diet can't beat it for your bone density.
Mhm. One thing I noticed with my own use of testosterone was better orgasm quality. So not
Yes.
just a higher libido, which happened,
Yes.
but I was very shocked to go, oh, I'm having better orgasms because they
Yes.
had gone down since when I hit the menopausal
Oh
range,
God, yeah.
right? It was like, oh,
Perimenopause.
what was that?
Yeah. It's like it takes forever to get there, and then you're like, that's it? That's all I
Oh,
got, right?
what? That's a ripoff.
I agree. Yeah. No, it's again that blood flow. So I tell women like the blood flow down to the genital area increases. You know, you and I were talking about we don't want to create a tiny penis down there, but we
No.
do want some engorging of the
Yes.
genital tissue and the clitoris, right? It needs, just like our brain needs blood supply, so does that part of our body. And that makes everything more sensitive. That creates more potent orgasm. So, oh yeah, huge difference, huge. And
Is
again,
this partially because of what it does for men with the nitric oxide? Because I've heard that estrogen helps to make nitric oxide in women and creates the blood flow to the vagina. But are we also getting that from testosterone too?
we are, yeah.
We
And
are.
again,
Okay.
there's your vasodilation too. Correct.
Right.
Yeah,
Right. It's
big
our
time.
it's our female erection. I had
It is.
Susan Bratton on the show and she was
Yeah,
talking about how our genitalia is exactly the same as a man's, but like inside.
it is. Just take it and tuck it in. I mean, the cool thing is though, is at the end of the day, we have no refractor. Well, we have very little refractory period. You know, it's there's a lot of factors in there, but yeah, we if our hormones are good and our blood flow is good, we should theoretically be able to have great orgasms. So
Yeah. Yeah. What else do you see? Anything else that maybe somebody would not relate to testosterone? Fatigue is a big one. The
yes,
chronic fatigue thing that you had mentioned earlier. I
yes.
definitely see women saying, "Wow, the energy has come back."
Well, you and I talked earlier about, adrenals and stress and how we're seeing a
Mm,
big drop in testosterone in women. We live in a stressful world and women are working and taking care of children and all of this. So starting at younger ages, I'll see drops in testosterone that maybe physiologically you wouldn't have normally. You put them on testosterone and again, mental clarity, mood gets better and energy gets much better. My sleep quality is better when my testosterone is good than when it's not. So there's definitely something to that I again can't
oh,
find
I
in
did. Yeah.
research. Yeah,
Yeah. I can't find that either.
no, but it's pretty fascinating. Testosterone, I see great improvements in collagen. Think look at how men age versus how we age, right? Typically, um, they we
And they're
have
such better sleepers,
yes,
I
right? How
think.
often you
Yeah.
don't? I mean, I have some guys with insomnia, but
Yeah.
we have a
Not
lot
as
more
many
women
as
with
women. Yeah.
insomnia. Yeah, and the collagen, it really, really improves collagen. So it's, improving cell turnover, muscle mass, bone density, like we talked about pain and all of that, cognition, sex drive, definitely. Um, no, it's one of my favorite hormones. It really is.
Hmm.
And the studies, like when I worked with Dr. Glazer, she said you treat to side effect. She said you treat to where the patient feels good and they're not having side effects because there is
Exactly.
not a harm to having higher levels. Doctors will freak out when they look at blood levels and go, oh my God, your level's 50. Like, okay, well, who cares? If I feel good, I'm having no side effects whatsoever, and I'm getting all these health benefits, there really is no negative to it. It's not harming the body. So,
I always say too that genetically, when you look at some people's genetics, and this doesn't go for everybody, but when you look at genetic profiles, you can see if a woman is more androgenic or she's more estrogenic. And you can actually just tell by looking at women, right?
correct.
If you've got the woman like myself who's got the hips and the thighs and the butt, and boobs. And then I always use my sister as the comparison because she's the exact opposite. She can't gain a pound without, she's
Yeah,
super wiry. She can eat anything she wants. She's shredded at all times. She can
yeah.
go out there and run a mile. She hadn't run in 10 years. Like she's just one of these
Nice.
people,
Right.
right? And those women I find if their testosterone just drops a little, like they could still be at 25, nanograms
Yeah,
and they feel it. Like it's
correct.
horrible for them. When for someone like myself, it's if my estrogen drops even just a little bit, and it
Yeah,
looked to any doctor would look at my estrogen and be like, "You're fine."
right.
And I'm
Exactly.
hot flashy and I just gained 15 pounds. I'm
Yep.
like completely falling apart.
Yes.
And I thrive on estrogen and I need my estrogen to be at a certain level.
That's a very good point. Again, it goes back to the every woman's different and everybody needs different things. But you're correct. I look at body types. Part of what I go through when I do my intake with the patient is I ask them like about their hormone history. How were your periods? How did you feel pregnant? How difficult was it for you to get pregnant? Those women who go, oh my God, I felt so amazing pregnant, never felt better. I'm like, all right, that's the girl whose body loves hormones, right? Estrogen and progesterone. And again, my thin, small chested, not big hipped girls, they can't tolerate typically a lot of estrogen and their body loves testosterone. So you're right. There is definitely something there on a more primitive level of what
Yeah.
is our norm for each person.
Yeah. Yeah. Do you find that most women in menopause start to need testosterone?
I would say in my practice, I probably have 90 to 95% of my women on testosterone and they love it.
Same.
you
Same.
know yeah,
Yeah.
it
Yeah.
really does make a difference. And I usually start perimenopause is when I typically start testosterone. you know the magic cocktail is usually the progesterone and the testosterone, right? They feel better, a lot better with that. So
Oh, I bet. And that would just help ward off so much of what's coming down the pipeline, I feel like.
absolutely. Yeah, because then I have a lot of my patients who, if they come in perimenopause, their transition to menopause is a cakewalk because they have, oh look, I'm starting to have a hot flash here and there, and I do some blood work and go, well, look at that, your FSH is climbing, you're starting to, have ovarian drop off. So it's an easy transition. So yeah, I always like women to come in when they start to be symptomatic in the
Hmm.
peri years for sure.
Yeah. I've been talking a lot on different podcasts about that. It's kind of what I've been really focused on in the last year in my business is trying to educate women and practitioners that women need help in perimenopause.
Absolutely.
Right? Like
Yeah.
so many practitioners say, well, you can't have estrogen until
Yeah.
you don't have any and
Right.
until you're in menopause. Like that
Yep.
is the standard of practice if they're
Yes.
even giving hormones.
Right.
It's like, no way, if you're getting a period, you cannot have estrogen. And
Right.
it's like, why? Why are we? And I think, would we do this to a man? Would we
No.
say to a man, oh, you can't have testosterone until you have zero?
No, absolutely not. And what I explain to women is you're still making hormones. We're filling the gaps, right? So if you have a month where all of a sudden your estrogen's jumping up and
Jumps
you're
up.
right, I'll
Yep.
go, call me. We're probably going to take you off of it
Yep.
for a month because your breasts are hurting and this and that. But no, they feel so much better because just because you're still getting, you and I know this, because you're still getting a period doesn't mean your levels haven't gone from here to here, and it does make them feel better. So fine, you still get a period, so be it. And no, I'm not going to give you a period till the day you die. I'm not a fan of the periods until I'm 90
Oh,
thing.
I am.
Are
I'm,
you?
oh, 100%. Yeah.
Oh God, I think I just don't want to do that. So
I know. And I say to women, I'm like, look, when we look at the science, there is things that are now pointing towards cycling progesterone, which
true,
is then you're going to have a period. If your estrogen's high enough in the
true.
therapeutic range, you are likely going to have somewhat of a period. But it's not the same kind of period that you had in your fertile years. And
True.
I think
You won't
that
get the PMSy stuff and all that.
no, I have no
Yes.
PMS.
Yes.
None. And it's like a 2 day period. It's super light. It's like, no big deal. So for me, but I
Doesn't
know that
bother you.
that's not for everyone.
No, I have women who lose their mind if they're,
Yeah.
if they, and then of course, providers go completely crazy if
Oh, I
you have a
know.
woman who's 60 who's having a
It
period.
is a bit weird.
Yeah, that makes you feel younger. So it's
But it's like, a 70-year-old still having her period. It does make you think like, that just doesn't seem right. But I think we just have to get over that, I think. But
I know in Europe, one of the things that I learned with the International Menopause Society is they do a lot of down regulation of progesterone for like a week versus the complete cycling. So they'll say down regulate for a week, let all of the receptors kind of take a moment and then get back on it. And that sometimes causes period and sometimes doesn't, but it's like a baby cycle. So,
Yeah. Yep.
you
And I
know,
say that to women. I'm like, you know what? If you're super dependent on your progesterone and you absolutely love it,
yes,
then, if you can just take 1 week off, do
yes.
that. If you
Or a
can't
couple
handle the
days.
two, you
Yes,
know?
yes. Yeah. Because a lot of women, you know how I don't feel good on it. And other women feel like it's God's gift to sleep and calm and every other thing. So, yeah.
And you don't feel good on it.
No, I'm one of those who feels cranky and get migraines. Doesn't matter what my estrogen is. It does not matter. I'm very grateful that I had a hysterectomy because um, I would be in big trouble. I would really be struggling right now.
Is that any type of progesterone, like topical and
Anything. Anything.
really?
It's not, I mean, it's awful, trust me, because I sleep like a baby if I take it, but I will wake up depressed. I will wake up with a migraine almost every single time I try it, no matter what I try. It's a bummer.
Have you
So,
ever tried taking it with dutasteride?
no, I have not. I have not. Oh, I'll talk about that one. Let's see.
Little trick. Actually, Kyle Gillette taught me that.
Interesting. No, I have not heard that.
Yeah, because it's I have the same thing. If I take too much oral, then I get depressed and weepy and like
Yeah. Yes.
topicals is fine, but yeah, oral not so good. And there's a growing number of women that can't tolerate oral. I'm just finding it more. Maybe it's because I'm one of the few that actually really understands it, I think, or
Yes.
like recognizes it, I guess I should
Right.
say. And so I get a lot of women that say, I can't tolerate progesterone. Karen, is exactly what you said. I have this progesterone sensitivity. But because dutasteride blocks that enzyme, the 5-alpha reductase enzyme. It's the same enzyme that's going to convert your progesterone into the allopregnenolone, which is the metabolite that's acting on the GABA receptor. And
Right.
we have a sensitivity to that neurosteroid. So it's neurosteroid sensitivity.
Oh, that's
It's
fascinating.
not
No,
that we have too much or too little. It's that we have this
diverse.
adverse reaction to it. And so that metabolite, because we produce mostly metabolites from oral progesterone, right?
Right.
We still get it from topical, and so you probably have like an extra sensitivity
Yeah.
to it.
Yeah.
Then blocking it with the dutasteride, you won't make as much of that metabolite.
Oh, I'm going to try that
There you
because it makes
go.
me sleep like a baby. I mean, I do
I
love
know.
hormones, but yeah.
Yeah.
Okay.
Yeah.
Thank you.
Yeah.
Yeah, because
Yeah.
if I take it invariably the next morning, I'm like, oh, there's the migraine again. And I've tried it sublingual, topical, oral. Yeah. Yep.
All
Yeah.
right.
Good. Thank
Well,
you for that info. That's
yeah, there you
fantastic.
go. I know it's so interesting to me.
I love that.
Yeah. Okay. So where can and you have a brick and mortar clinic, which is so
Yes.
rare to find these days. You're in California, so she is taking patients, and she has two other women that work with her who also take patients. Correct?
Correct. Yes, we do. We're in Southern California in the Thousand Oaks area, which is like north of Los Angeles. And cute little clinic, great staff,
I
and
bet.
yeah, and very, very, very happy. Yeah, very happy little clinic. Everybody's pretty pleased with it. So,
I actually went to see if I could poach you from someone. I'm like, you know what? I would listen to this great business podcast where the guy was like, if you go to pay somebody like an extraordinary amount of money just to get them to come work for you, do it. It'll be worth it because if they're really that good at what they're doing, then pay for it. And I'm
right.
like, yeah. I'm like, who could I go poach? And I'm like, Christine Farrell.
Oh,
So I went
Karen.
onto your website and I'm like, damn it, she owns her own clinic. She's not going to
Yep.
want to come over to mine.
Thank you, though. I love that. No, I really, I kind of, I do my online stuff. I've got my Instagram stuff and my whatever, but I do that because I love it.
Yeah.
And, I just enjoy the educational piece. I teach for UCLA. So it's kind of a pet project of mine to do exactly what you're doing, like to help educate women about hormones and the cutting edge stuff and the right and wrong, because there's so much misinformation out there right now. It's really hard.
Well, let me give you an open invitation that anytime you I'm not saying to come work for me. Yeah, that too. If you
Down
ever
the
decide
road,
to shut your practice down and
you
come
never
work for
know.
me, I'll pay you.
Okay. Deal,
No, what I
deal.
was going to say was an open invitation to if there's anything that you ever want to discuss on a podcast,
Okay.
that you're hot on, then you just reach out and you can come on anytime, Christine,
Thank you.
because I'm all about the education for women as well. And I have this incredible platform. We're almost at 2 million downloads right now. So like
Good
we're
for you.
this far
That's
away. Yeah, we're
awesome.
at 50,000 downloads a month, and
Wow.
so and very quickly growing. So I just feel like, oh, I just seen this like wave happening where I'm like, come on, just keep going, keep going. I want to reach as many women as I possibly can with this information.
Yeah, don't stop because it's so necessary and you're putting out good, solid information. So I love it. Keep doing it.
Minus that testosterone is our most abundant hormone.
Well, whatever. You and I will keep researching that and
Yes,
figure it
we
out.
will.
We'll come back.
We're gonna come back to that, everyone. We're gonna push pause on this
Yep.
information and we're gonna see if we can find more accurate information about it.
Yes, I will. I will. Now I'm on a mission. So
Same. All right. Well, thank you so much for coming on the show. I'm going to link to everything in the show notes, you guys. I would highly recommend following her on her Instagram channel. She's always putting content out, and it's always great content. I'm always loving it and have for years. So I'm just so happy that I finally got you on this show, and I can't wait to have you back again.
thank you so much for having me. I really loved it.